Good morning, good afternoon, or good evening to all of you, depending on where you are in the world. I want to extend certainly a warm, genuine welcome to each and every one of you for our 2022 NSBA Dysphonia International Symposium. I realize that a few of you may not be familiar with the words Dysphonia International for our organization, but we have a session later in the program where we'll go into more detail about the transition of our name change. So for those of you who have heard me and other leaders over the past 2 years talk about it, expanding our mission and changing our name, really the purpose to be more inclusive for people with voice conditions other than spasmodic dysphonia. So we start the program today with a panel of researchers. I'm just absolutely delighted to have all of the researchers who are doing just phenomenal work and projects where they are looking and striving to find more answers for those of us with voice conditions. So we're going to just jump into the program here, and I think we'll start with Juergen.
Start with me? Good. Yes, good morning, everybody, or evening, afternoon, depending on where you are. My name is Juergen Konczak. I'm a professor at the University of Minnesota, and my co-worker Divya Bhaskaran, Dr. Divya Bhaskaran, is also here in the call. We have been working for some time now on non-invasive treatment to symptomatic treatment for spasmodic dysphonia, where we do vibration of the laryngeal area. We've been working with NIH, and we also got, thanks to funding from NSDA, soon to be Dysphonia International, we got a support to do several clinical trials. One specifically on a long term, about 3 months long, that is NIH funded, where we work with people with adductor spasmodic dysphonia, and the NSDA trial is with abductor spasmodic dysphonia. We are at this point now where I can tell you that it works. It works for a subset of people that they get benefits. Roughly around 40 to 60% of people get benefits. Either their clarity of voice gets better or their effort is reduced. And the good news is it can work with abductor SD as well. And Divya is our clinical coordinator. She really has done a tremendous amount of work and interacting with people who are coming in here. Divya, I don't know whether you have a few words to say.
Divya, if you don't mind, just before you start, let me remind everyone we welcome and want your questions. And the way you submit those is just type them into the Zoom chat box, and we will try to answer as many as possible. So, Divya, all yours.
Oh, thank you. I think Dr. Konczak mentioned everything, and I'm just here. If you have any questions, I'll chime in. But I think Dr. Konczak mentioned everything we do. So I'll pass it on to the next person.
Okay. Thank you, Juergen. Anything else at this point?
So, do you want more? I mean, I can provide a lot more detail. I thought we'd just give a short intro now, or tell me what you want. I'll be happy to talk more, or people can go to our laboratory website. That's hsc.umn.edu. I'll put this into the chat too. And they can get more information about these clinical trials if they want to contact us.
Yeah, if you want to just comment a little bit more about the neuromodulator and what it is and from your perspective how it works.
Okay, this is this notion. What we are literally doing, they are like small vibrators. They're what they call encapsulated. So they get in contact with the skin. They vibrate somewhere between 40 to 60 cycles per second. And what it does, what we know now throughout our research, is that stimulation here will, of course, get registered in the somatosensory cortex, and it modulates motor cortex and those areas in motor cortex that are involved in the control of speech. And we have done now enough research to show that, yes, there's a very immediate response. So when you do this for those people who benefit from it, it's relatively fast. So which really means within minutes, 20 minutes or so, you'll have an effect. Some of them will not have an effect. So I don't want to oversell it, but those who respond quickly. And of course, I'm literally working with NIH on a phase 2 clinical trial now, where we're trying to figure out what is the optimal dosage, because in our current clinical trial, people only do this for 20 minutes, 1 day a week or 3 days a week. So it's a relatively low dosage. So that's where we are. And we've got lots of responses from patients. Some also indicate that it may, many of you get Botox, and some said they get the feeling that the benefits of their Botox cycles are longer, so that it doesn't go down in the later part of their Botox cycle. And that's some of the things that we also see in our data. And literally, Divya and I are basically writing up the first scientific manuscript to summarize these data.
Okay. We have a question, Juergen, for you or Divya. Do you guys have a photo or a picture of the vibrator that you can show everyone?
So maybe I can try to get one from Mike. Divya, do you have something? Otherwise, I'll try to go to the
I don't
server.
have it.
Allow me, I'll try to look for one, and I'll try to put it into the chat box.
Okay.
Yeah, and we can circle back too.
We can,
no problem.
We can come back to that. Quickly, another question was, to what extent is the impact of the vibrator a temporary effect? And do you have any data on how long the positive effect lasts?
Yeah. So I can tell you right now, if you do this for 20 minutes, you see an effect within these 20 minutes. For most of you, it will decay slowly. So you will have about an hour, half an hour to an hour, it will last. Now, what we don't know, and this is one of the things that we are working on, and if you do this more often, will it build up over time? That question we have not answered. But if you are just doing it one time, you get a benefit. It's roughly an hour after stimulation. You still may see benefits. And then it will decay and it's gone.
Have you, based on the work that you have done thus far, do you see a segment of patients where it's more effective than it is with other patients?
This is a very important question. And honestly, we don't have those data. What I can tell you, we have people with Botox and we have seen people without Botox. Both of them can show benefits. So that's what we have seen. We also see that those who are more severely affected also receive the biggest benefit. They have, so to speak, the biggest room for improvement. And that is something that we see.
Okay. All righty. And we'll circle back as time permits and pick up a few of the other questions that we have. At this point, I'm going to shift over to Vincent, Dr. Gracco, talk about the work you are doing in your team.
Thank you, Charlie. Well, I feel a little hesitant to talk about too much because this is a project that really is, although it's a very small quasi-clinical trial, it's based on some hypotheses about LD and how we might be able to modulate the effects of LD using transcranial direct current stimulation. I wish I had some results to tell you about, but I don't. But I can give you an overview of the approach. So the idea basically is that laryngeal dysphonia, or formerly known as spasmodic dysphonia, is a network level disorder, which means that it doesn't necessarily reside in a single brain area, but it involves a network of brain areas that work cooperatively to produce voice or speech. And the assumption is that this network has become somewhat imbalanced. And by imbalanced, what I mean is that the relationship or the concentrations of neurotransmitters, excitatory and inhibitory neurotransmitters, have become modulated or modified. And what we see in the voice is a manifestation of that. And we think that with transcranial direct current stimulation, which we know can have an influence on excitatory and inhibitory neurotransmitters, specifically glutamate and GABA, it's possible to modulate the concentrations. However, the one quasi-novel aspect of this study that I think is, I think potentially is very interesting, but we'll see, and it depends on how the data come out, is that instead of, in typical transcranial direct current stimulation, you use a very large sponge electrode over a brain area that you're trying to target, and another sponge area over a relatively neutral area or on the other side, and you drive a current or provide a direct current, something that you would get out of a 9-volt battery. So it's relatively non-invasive and relatively painless. And you can change the membrane potentials of the brain areas underneath that electrode. However, this is a very gross and a very diffuse approach, and it's become clear with a lot of recent data that what you need is something a little more focal. And there are ways of being more precise in terms of what the areas that you're stimulating. What we're doing that is somewhat novel, or will be doing, which is somewhat novel, is that we're targeting multiple areas simultaneously. So we can put sets of electrodes, stimulating electrodes over, for example, the motor cortex, the sensory motor cortex. We can put them over the auditory cortex. We can put them over the cerebellum, inferior frontal regions, depending on the specific network that we're able to identify from the individual patients. And then we can, based on the information that we get, we can modulate those areas, either upregulate them with excitatory stimulation or downregulate them with inhibitory stimulation simultaneously. So the idea is that the behavior that we're looking at when people produce speech or voice is distributed across multiple regions of the cortex. We're going to identify those regions, although we know pretty much where they are. in individual patients using functional magnetic resonance imaging, and then develop stimulation montages or stimulation patterns in which we target those areas that are operating differently to try and bring them into balance. And in addition to doing this, we're also doing this over an extended period of time, over a 2-week period, where individuals will come in for about an hour a day, 3 times a week over a 2-week period. So we can look at the long-term effects. We can also look at the effects based on consolidation or what happens when they after sleep. That's why we do it every other day. And then we'll also then put them back in the scanner and see if those areas have specifically changed in terms of their patterns of activation. And then we'll follow them up in another week to see if there's any long-lasting changes that are obviously resulting from the stimulation, but independent of the stimulation. And so that's kind of where we're going. We really appreciate the seed funding from the association, because it'll allow us to get the pilot data that we need to determine feasibility for a larger NIH-funded clinical trial.
So, Vincent, how many people are you looking to participate in this initial phase of the project?
Yeah, in the initial phase, we're just looking at 10 individuals with LD and 5 control subjects. And so we'll have 5 LD participants who are getting active stimulation, 5 that are getting a sham stimulation, and then 5 individuals, non-LD participants that won't receive any stimulation, but they'll engage in the same task. And I should also mention that the stimulation will be delivered during a specific task over a 20-minute period within the testing session. We're going to use this conversational technique where it's called a diapics, where you give 2 individuals pictures and they have to communicate back and forth about what's different in the picture. So there are 12 things that are different, and that'll not only provide the behavior that's important, because stimulation, direct current stimulation, works much better when it's being delivered during a behavior. And it also gives us a whole set of things that we can evaluate in terms of the immediate effects, as well as the pre and post stimulation behaviors that we'll also evaluate.
Okay. A couple of questions, Vincent. One is, will you have people with both AD and AB participate in this project?
Not for the pilot project. We want to try and, because the numbers are small, we want to keep it as homogeneous as possible. But, even as I'm sure you know better than I do, that even within the AD or AB group, there's a lot of heterogeneity. So we thought it best to just focus on one particular.
Okay, excellent. Another question. Are left-handed people eligible for the study?
Yes.
That's an interesting question that comes up so often with some of these research projects. So good.
And there was one more about, will they need to be Botox free?
Yes. Yeah. There'll have to be a bit of a washout period between.
Or what period, Vincent?
Well, I think at least 6 to 8 weeks, maybe longer. I'm not quite sure what the optimum is. I think we proposed something in another venue, and I was told that probably wasn't long enough. So we want to make sure we have the right. We're still researching that.
Okay. Sounds good. All right. We're going to move to our next study and project, and Dr. Christopher Honey.
Thanks, Charlie. Hi, I'm Chris Honey, professor and head of neurosurgery here in Vancouver, University of British Columbia. And my work is focused on deep brain stimulation. We have done 1,000 patients with Parkinson's and a variety of dystonias, and we've taken what we've learned from that into spasmodic dysphonia. It's easy to talk, but sometimes it's nicer to hear and have actual examples. I'm going to try and share my screen if that's okay.
Yes, sir.
Yeah, I'll see if it works, but share sound, optimize for a video clip, and let's see if I can share it. Charlie, are you seeing a rogues gallery of researchers?
Yes, sir.
So, see if this works. Is that working too?
Yep.
Okay, so this is a collaboration between the University of Indiana and the University of British Columbia, and we've tried to bring together a group of people interested in spasmodic dysphonia. I'm a neurosurgeon, but we have laryngologists in Indiana, Stacy Hallam and Amanda Hu in Vancouver, and we have speech-language pathologists, Rita Patel and Linda Ramich. And our overall arching goal is to find the cause of SD and find a single treatment that can correct it. A lot of patients are doing fabulously well with Botox, but it does require multiple treatments. And there are some people who the Botox, it doesn't work for anymore. What are they going to do? And we also wanted to find a treatment that would correct all forms of SD. So the common adductor, but also the more rare abductor. We've published our initial pilot trial on deep brain stimulation for spasmodic dysphonia. And the trial was designed to blind the patients. They didn't know whether the stimulation was on or off. You can't feel the stimulation. And then we asked them about their quality of life after 3 months of stimulation. And those with on were much better than those that were off. And similarly, we measured their quality of life before surgery and 1 year after surgery to show that it was a robust and long-lasting effect. So this is only with a very small group of patients, only 6 patients.
And the sunlight strikes rainbows in the air. They act like a prism and form a rainbow. The rainbow is a division of white into many beautiful colors. For the public.
Trying to read the rainbow passage. It's a standard sort of phrase that we get them to try and read.
Gold.
Can be stressful. And this is with the DBS.
There is, according to legend, a boiling pot of gold at one end. People look, but no one ever finds it. When a man looks for something beyond his reach, his friends say he's looking for the pot of gold at the end of the rainbow.
Wow. Very good.
So if it works for changing the cause of dystonia, it shouldn't matter what kind of muscle is affected at the end of the line, whether the muscles are pulling your vocal cords open and giving you abductor or pulling them closed and giving you AD. And so we've actually now operated on a patient with abductor SD. It's a relatively rare, and I wanted to give you a chance. I think this might be the first time we're showing the voice. It's published. This is him answering a question, what did you do last weekend? And basically there's a mountain in behind Vancouver where people like to hike up. It's quite a hike. And he's talking about he's done the hike 3 times. This is with the DBS turned off. This is his voice, and it's a characteristic wispy abductor.
Pretty boy, Friday went to bed early, and Saturday morning went hiking at Minneapolis Park for 1 hour. Didn't do much that afternoon. Sunday morning went to Grouse and did 75 minutes
it's hard to understand him. He's quite wispy. And this is answering the same question with the DBS on. So I'll give you an example of what it's like.
Last week I did the Gracco 3 times. Saturday, previous Saturday, Wednesday, the following Saturday. The first Saturday was the first time of the year post-COVID, and it was grueling, but the third time was a definite improvement. There's many new COVID restrictions on the grouse. Now you wear a mask on the tram, and everybody has a designated standing spot, and you sanitize before you go in.
And so he's actually now working with a speech language pathologist because we've given him his power back, but he has to learn really how to re-talk again. And I would add that hiking grouse scrying 3 times over a weekend is quite spectacular. And so we do have some interesting sort of advances that it's very early on. We have one patient with DBS who's now 10 years out, and when you turn off their DBS, their voice is still normal. They actually had DBS for a different condition. They had it for tremor, but they also had spasmodic dysphonia, and the spasmodic dysphonia got better serendipitously. And when we turned the stimulator off, after 10 years of stimulation and neuromodulation, their voice continues to be normal. And he will let us turn the device off for a week, but the problem is he's got bad handshaking, so he doesn't want the device off forever. But it was interesting for us that 1 week later, his voice was still normal. So we wonder if SD is not carved in stone, but is possible that it could be neuromodulated. We're looking at specific targets in the way of these various pathways that you've heard about earlier, and we know exactly where our electrode is, and we can see exactly what are the pathways in the brain that we are modulating. And finally, I was at an SD meeting in Boston a few years ago, and the focus of the meeting was really adductor, and there's always lots of benefit for those patients, and Botox worked very well for a lot of those patients. But I wondered, we needed some kind of therapy that would be very good for all forms of laryngeal dystonia. And also, what do you do for those patients where the Botox isn't working? We need additional therapies for those patients. And so ultimately, I believe that deep brain stimulation is not going to be the go-to therapy that once you're diagnosed. I think deep brain stimulation will probably be, the last resort. If you've tried this and it doesn't work, and you've tried that and it doesn't work, now you still have an option. And also, I think it might be a very good option for those patients with adductor spasmodic dysphonia. So all of our trials are on our website at stopsd.com, and you're welcome to have a look. So I'm going to stop sharing. There, I think that worked.
Okay, Chris, there's one question that really relates to the procedure itself. This person knows someone who had DBS for Parkinson's.
Yeah, so
the question is the procedure and the placement of the transmitter basically the same?
Basically the same, yeah. And I can read the chats too. So there's an electrode in the brain. This is invasive. This is not non-invasive, not like Juergen's on the skin. This is in the brain, in the circuit that is triggering your voice. And it's connected underneath your skin to basically a pacemaker that sits in your chest. And it will go 24/7. You're not aware of the stimulation, but it's constantly working.
Okay, excellent. Let's see, any other questions that Kim, any here that I've skipped over or we haven't answered for any of the researchers?
Yeah, there's a question. I got it. There's a question saying, can you reprogram if needed? Yes, you can. So you would visit the clinic, and through your shirt, we would put a computer on your shirt and adjust the stimulation to match what your brain needs. So your brain might need more or less than the next person through the door. And if your disease is progressing, 5 years from now, you might need yours turned up a little bit. So the strength of this particular technology is that it's adaptable. Yeah, and if you get a side effect, if you get some tingling because we've turned the stimulator up too high, we turn it down and adjust it to what the patient needs. Question is, what is the target for DBS? It's the ventral intermediate nucleus of the thalamus. What is the recovery time after DBS? You go home the next day. What are the side effects? So the side effects, if you turn the stimulation up too high, you can get tingling. This is an invasive procedure, so there are risks associated with surgery. If you get a stroke when you pass the electrode through the brain, you're in big trouble. And so we have had no complications in our SD, but the numbers are so small, it's only 6. So if you extrapolate from our Parkinson's, I have operated on 1,000 Parkinson patients over the last 20 years. We've had no deaths, and we have had 3 strokes. Most of our Parkinson's patients are quite elderly. You might think that they're at risk for stroke, but so the risk for stroke is 3 in 1,000 in our hands. There is no age limit. It's certainly well, we like to tease our Eastern colleagues that a 65-year-old person from Vancouver is more healthy than a 50-year-old from New York. So it's more what is your physiological age? And we do 80-year-olds with tremor, not frequently, but we have not used age as a cutoff. Ataxia is a completely different neurological condition. It's a lack of coordination through the cerebellum, and deep brain stimulation is not good for ataxia. Is SD caused by overactivity? Oh, wow. So I'll read it out loud. It's a complex question. Is SD caused by overactivity of the basal ganglia, widening of the basal ganglia, or shrinkage? Why do anti-anxiety meds help SD sometimes? Please explain the mechanism. Yeah, so it's not an anatomical shrinking or growing. It will be more, we think it's more a pattern. It's an overactivity through one area where normally when you contract your hands, you squeeze these muscles but relax the other muscles. And if you don't do that in a coordinated fashion and contract both sides, you'll get abnormal sort of dystonic movements, and that may be happening in the throat. And why do anti-anxiety medications help? Most dystonias are worsened by anxiety. Most tremors are worsened by stress. And so I am extrapolating from a large knowledge of operating on dystonia patients and a very small knowledge operating on spasmodic dysphonia, but it's probably very similar. What are your plans for expanding your work in SD patients? So we have been funded by the National Spasmodic Dysphonia Association to do a phase 2 trial. So our initial trial was a pilot trial. Phase 1 trials are basically, can you do it without hurting people? Answer, yes. And phase 2 trials is, okay, now are you absolutely sure that it's beneficial? So easy for me to say, yeah, it really works well, and to maybe show you one example of someone that did well. No, you need a group of patients and one with stimulation, one without, and see how they do. And what we're doing with our trial that's been sponsored is that it's the same patients. The same patients have a 3-month window when their stimulation is on, because you can't feel if your stimulation is on or off. How is your voice? How is your quality of life? Then they're switched over, stimulation on. How is your voice? How is your quality of life? So we're using individual patients to compare against each other. And with a group of 10, we know our power calculations will show that the device is effective or not. Has there been any improvements in Botox injections in the past year? Sorry, you're asking the wrong guy. I don't do Botox injections, but one of the things about DBS is it's invasive. You know, whereas Botox is just I mean, I know I haven't had it done, but I heard it hurts, but it's like, it's just a needle in the throat. And if that's working well, or, you know, if Juergen's device works well for you, why would you have brain surgery? You know, we're looking for the patients who aren't doing well with the current therapies. We want to have an additional therapy for them, and one that's long lasting. The only thing that we're quite excited about is the potential of neuromodulating and curing the disease. We do have that N of 1, so take it with a grain of salt. We do have that one patient that's 10 years out from DBS and their voice is normal. Oh, holy, I can't keep up with it. Something about, interesting, I have OCD also, and I know that the striatum is also where OCD happens. Yeah, so obsessive compulsive disease is another condition that is treated with deep brain stimulation. Right now, those are just in trials. But there's a lot of work out of Holland, and there's some a preliminary research work out of the United States, where the basal ganglia circuit is being modulated down for OCD. But that's not what we're here to talk about today, I'm sure. Well, I'll just read this out. From the question and answer section, I often have trouble getting my thought to my voice. I call it a silent stutter. Mentioned it in ABSD support group, and several others have this problem. Is any research being done in studying the movement of the signals along the neurons of our brains? Yeah, yes and no. Not my field. We know, and Vincent has touched on it, that it's a circuit in the brain. There are multiple circuits, and you're talking about a circuit getting from your thought down to your voice. We're often focusing on what we hear coming out of your voice, but it is definitely a circuit. It's not like one spot that's wrong, and if only you could fix that one spot. It seems to be, yeah, it's a circuit. Sorry, I meant I have ataxia and ST. Can that still be an option for SDAB? So just so you know, ataxia is a very difficult, that's an incoordination that someone who is drunk looks like they're ataxic. And that is a very difficult neurological condition to treat, and it is not successful with DBS. SD is a condition that can very well be treated. Absolutely. Is it possible that EBV, and I'm guessing that's Epstein-Barr virus, causes SD? If only it was so simple. Yeah, if only it was so simple. Yeah. I don't think so. Epstein-Barr virus is very, very common. So common in the human condition that it appears with multiple different diseases, known to cause leukemia in some patients, but most often asymptomatically present. But it is such a ubiquitous virus that it's often found with many conditions by chance alone, not expected to be the cause of SD. And my SD progressed greatly after having severe pneumonia for several months. Yeah, so for multiple reasons, but you know, the stress of that, but also you need breath control when you do spasmodic dysphonia. Sometimes the patients sound very normal, but they're working really hard. You throw off your lung capacity, and your ability to generate voice will also be thrown off. But I'm hoping that it'll recover after you recover from your pneumonia. But it might take a little while.
Yeah, I'll just Chris respond. There's a question about the thyroplasty surgery done in Japan. The folks we have on this panel are researchers and not laryngologists who are actually doing, whether it's Botox, as Chris said earlier, he doesn't do Botox injections, or certainly the thyroplasty is more obviously a surgical procedure. So,
have you seen COVID-induced SD? No, I haven't, but would better to ask a laryngologist about that. Do you see a connection between SD and lupus? Both connections seem to get worse. Yes, well, there are both conditions seem to get worse with stress and anxiety. Many conditions get worse with stress and anxiety, and no, SD and lupus is not necessarily linked. It's quite, just because you have SD doesn't mean you might not have some other problem at some point in your life, and they're not necessarily linked together.
And we did have a question from the question and answer section, and this is really for all three researchers. Have any of these treatments shown improvement with the singing voice? I have SD with both my singing and speaking voice.
Yeah, so we haven't actually tested our patients with their singing voice, but I thought most people with SD can get better with the singing voice, but clearly not everybody. But no, we haven't. In DBS, we haven't tested singing voice.
We've had that question in the past as well. Whether it may help improve singing voice. We haven't studied this systematically, but like as Chris said, I would assume if it works for speaking voice, it should have a benefit on the singing voice as well. But we haven't done this systematically. But yes, we have gotten requests about this, yes. I don't know.
The same with my experience, as Dr. Honey said. Some of the patients who come in, they say, I can sing it better than I can talk it. But I have not, we've not tested it out. Usually our tests are done on speaking certain sentences and passages like Dr. Honey is doing. Yes.
Yeah, it's an interesting phenomenon in that we hear all the time that some people with SD can sing very well. Some people can laugh or cry, and the SD does not seem to affect those emotions at all. So it's an interesting phenomenon to some extent.
Yeah, and Charlie, if I may add, and this is just purely hypothetical, and I don't have a lot of data to support it, but we found that the brain abnormality in SD is very lateralized. It's not on both sides, it's very lateralized, and speech very much comes down through the dominant hemisphere. Speech, everybody knew language does, but we've shown speech does as well. And as you may well know, singing is on the other side and might be coming down through a different pathway. I did notice one question that said that my SD goes away when I whisper. And that's a clever trick. And the speech language pathologist will tell you that your SD probably is a deductor. And what happens is when you whisper, your vocal cords are pulled open. And I don't know if you listen, but that first patient that I showed with the adductor, she was struggling and then she started to whisper. And it's a trick that they used when you whisper, your vocal cords open up and it counteracts, but it only counteracts adducting. So it's a well-known speech language pathology trick.
Right. Yeah, also the comment or the question here where people have mentioned about maybe speaking a different language. Again, that's something that SLPs, we hear from SLPs quite often, that again, that's one of those things where it's interesting. You got the SD in your native language, but then you speak another language and you don't really hear the SD.
Which speaks to pathways, right? One pathway versus the other pathway, very close, but slightly different pathway, which is what Vincent is going after. What's the pathway?
Mm-hmm. Right. Oh, here's one that comes up a lot over the years is SD genetic. Well, I will comment briefly. We work very closely with a couple of experts in the area, and there's been some small studies done. There really has not been a study to definitively say that it is genetic. But having said that, a lot of people highly suspect that it may be. So that was a roundabout way of not particularly answering your question because we really don't know. Yeah, this question about Robert Kennedy Jr. and yeah, there are some familial cases with SD, and those have been a couple of them have been documented by some of the genetic researchers. Chris, here's one. Said you mentioned Parkinson's. Have you seen patients with MS also experience SD? There was an actress with MS that developed SD.
Yeah, no, we see SD, or I see SD in conjunction with tremor. So I think almost, if I get this correct, almost half of the patients with SD have tremor. And about 1% of our tremor patients also have SD. So tremor is much more common. And that's really what led me to this field, because I operate on tremor and I've operated on hundreds of them. Some of them happen to have SD as well, and their SD got better. And that was pure serendipity. And so then we looked into, oh, what's happening here? But MS is a disease where you get multiple hits in different parts of the brain at different times, and sooner or later, by chance alone, one of those hits might be in a circuit causing SD. But it's not a common connection, MS and SD, whereas tremor and SD is a fairly common connection.
Do you think the other treatments that we've talked about today would also help tremor? Have you, is that something that you would also be looking at, either Dr. Gracco or Dr. Konczak for vocal tremor?
Well,
sorry, Vincent, go ahead, please.
Well, I think that I'm trying to remember because direct current stimulation or other forms of current stimulation have been applied to individuals with Parkinson's disease, but not specifically for the tremor, unless I'm not thinking straight. But I think there's certainly some possibility. There's another way of using the current stimulation, which is you use an alternating current, which can be modulated based on the rhythm of certain brain or frequency responses, brain signals that might be more effective for tremor. But I don't know if any studies that have actually focused on that, but it certainly has some potential anyhow.
I can just add to this. So as Divya had also said in the chat, we are doing another clinical trial with people with cervical dystonia. And of course, there's a very similar, that sometimes you have people with cervical dystonia and cervical dystonia plus tremor. So we have evidence that for some people who respond to this, so we just had a gentleman in our lab where we actually did the trapezius, so the neck muscles at the back, and we stimulated this. And it had a grave effect on his tremor and his muscle spasm. So it would be similar to what Chris has seen in this N of 1 patient, where this person has tremor, gets DBS for 10 years, and the voice also gets better. So I would think that if you do this type of neuromodulations, whether it's non-invasive, like what we do, which then eventually modulates motor cortical activity, or whether you do it invasively through DBS, it should really affect motor cortical output, and it should help with tremor as well. Although there is a whole set of other literature that also talks about whether the tremor has, we spoke already about this, has a cerebellar network component versus the muscle spasm is more on a basal ganglia circuit tree. So this is certainly out there, but there has not been any systematic research on this at this point.
Okay,
Thank you.
Good,
Appreciate
good,
that.
good feedback from both of you guys. Kim, any other questions that you've received? I think we've covered all the ones in the chat.
There was one of the other questions is, we talked a little bit about, most of the research study is on ED because it's more common. And so, one of the challenges we hear also is, what will any of these treatments be effective? And this is why I mentioned the tremor, because there's a question is, I have AB, AD, and essential tremor. So kind of the trifecta. And so, and I realized too, with the research studies, you need to have that consistency before you can go on to these other more complicated forms.
So AB plus AD is called mixed, and we've operated on a mixed, and it works. Yeah. But one, yeah. And in the trial that we're doing, that we talked about with the NSDA, we're doing AD and AB, but we're actually not doing mixed. But we would have thought that if it works for both, it should work for mixed as well. But they're rare, yeah.
Right. There's a question, have you studied the effects of kinesiology on the SD voice? Any of you have any information on that?
What is meant by the effects of kinesiology? I'm not exactly certain of what Jill is referring to.
The person that asked the question, do you want to elaborate just a bit?
Yeah, so I can guess. Kinesiology is the study of movement. And people who study kinesiology at university go on to be physiotherapists. And so I'm guessing exercises. Speech-language pathology has lots of exercises and tricks for spasmodic dysphonia. And that would be kinesthesiology of the larynx would be a speech-language pathologist, I think.
Good point. Good point, Chris. Excellent. Okay, at this point, unfortunately, Dr. Scott Norris and his colleague, Dr. Evan Gordon, couldn't join us for the session today, but they did a video for us. So we're now going to show the video of Dr. Norris's project.
Hi, I'm Dr. Scott Norris, a neurologist at the Washington University School of Medicine.
And I'm Dr. Evan Gordon, a neuroscientist at Washington University.
Adductor laryngeal dystonia, or spasmodic dysphonia, is a disorder resulting from involuntary spasms of the tiny muscles of the larynx that cause the voice to break or sound strained, tight, strangled, or breathy. This disorder affects over 50,000 people in North America alone, contributing to substantial disability in those affected.
What causes adductor laryngeal dystonia? We aren't sure, but we think it's related to abnormal interactions between brain regions that coordinate and control movement. This includes the motor cortex on top of the brain and structures deep in the brain, such as the thalamus, the cerebellum, and the basal ganglia. These deep brain structures are in constant communication, forming a network that helps regulate the function of the motor cortex. If communication is disrupted between these brain regions, it causes problems for how the brain controls your muscles and speech, thus resulting in laryngeal dystonia.
The standard treatment for dystonia is to inject botulinum toxin into the affected muscle. For adductor laryngeal dystonia, that means injections into the voice box. This reduces symptoms, but it isn't a perfect treatment. For one, the process may be uncomfortable and may cause breathing or swallowing problems. For another, dystonia isn't due to problems with the muscle, but rather originates in the brain. Thus, we're currently treating the symptom, not the cause. If we want to learn how to treat the cause of dystonia, we need to improve our understanding of what is happening in the brain.
This has been challenging to figure out for a number of reasons. One of the most important is that every individual's brain is a little different, and there's no guarantee that the disordered circuitry in one person's brain will be in the same place as in another person's brain. However, we've recently made important progress in understanding this type of patient-to-patient variability, and we've learned better ways to map brain networks in each individual.
In our planned study, we will use magnetic resonance imaging, or MRI, to evaluate how brain regions communicate in individual patients with adductor laryngeal dystonia using very high precision methods. We will then determine how the function of these brain networks change when an individual is treated with botulinum toxin injections. We will do this by comparing precision MRI pictures of the individual's brain before and after botulinum toxin injections.
Mapping dystonia-affected brain networks in individual patients will give us the ability to determine patient-specific targets in the brain for future interventions. And describing symptom-related changes in the affected brain networks will give us important information about what effects those future interventions will need to induce in order to alleviate symptoms.
We anticipate our findings will guide future researchers attempting to alter how the brain communicates, using methods such as deep brain stimulation surgery, transcranial magnetic stimulation, or newer methods. Specifically, we hope our research shines a spotlight on regions of the brain that are important in individuals with laryngeal dystonia and successful treatment.
We are very excited to start this study, and we think we have a chance to make a real difference in the lives of patients with dystonia.
And finally, we want to thank the National Spasmodic Dysphonia Association for generously providing the funding to conduct this work.
Okay, we got a brief overview and sense of Dr. Norris and Dr. Gordon's work. And, I think what excites me most about the work that we've heard discussed today and other research that's going on is how we're now beginning to focus in on the potential cause of SD and perhaps a couple of these other voice conditions that we've talked about. And I think the other important thing has been discussed is the collaboration between centers. As Dr. Honey talked about working with the center in Indiana, those are important steps forward for us to really get a broader base of research going. And that's how we're going to move forward to gain more understanding about these voice conditions and lead us to certainly, I'm convinced, better and more effective treatment options in the future. And ultimately, we're going to get to the point where we really start to understand the real causes of these conditions. And so it's all exciting. It's fantastic work, and I can't thank all of our researchers joining us today and others around the country that we're working with. And it's an exciting time for those of us living with a voice condition. And for many of us, we think back just a few years ago where we were, and I know Dr. Honey and I have talked about this several times. You think back to even 5, 6, 7 years ago to the amount of research and the number of researchers even working on voice in total were the number was very, very small. So now we're seeing more researchers interested in voice, and that is truly exciting and heartwarming for us as an organization, and certainly for those of us living with voice conditions. So again, I can't thank all of you enough for participating today, but more importantly, for your commitment to helping us find better and more answers for our voice conditions. So, Dr. Honey, Juergen, Vincent, Divya, thank you guys so much for participating and all you are doing.
And we could go around if you'd like. We have a few more minutes to do some closing comments from each researcher if you'd like.
Sure. Juergen,
any last final words of wisdom? Very good. I think I have been in this field now, really working with laryngeal dystonia for the last 80 years. And I think if you just look back, it sounds like a long time, but clearly we have a lot more understanding of what is going on. When I started out, it wasn't even classified to be a dystonia. It wasn't like, yes, it's there. We don't know exactly what it is. And I think we have a much better understanding now. And I think, you know what, Dr. Honey, as invasive, our group on non-invasive forms of neuromodulation, the work that Vincent is doing, I think we are now getting to a point trying to build upon this understanding of a network disease and then trying to modulate that activity and alter it properly. And I think there's great promise on it. But again, I think there's a lot of work still to be done to do it right.
Divya, anything to add?
Yeah, I think it's been, I think, thanks to NSDA for like organizing this and helping, patients communicate with researchers and us also talk to them and learn from them. I think I just want to answer one question is the mixed SD. We haven't had many participants with mixed SD in our study, but just because it's a rare population, so it's difficult to conduct studies on that. So we don't know how our vibrotactile stimulation works with mixed SD. But hopefully, like thanks to NSDA, we were able to conduct a study with AB doctors specifically for that population. So I think as our device keeps, getting to the next level, we'll be able to accommodate more people with different types of with tremor or with mixed SD, things like that.
Good, thank you. Vincent.
Well, this is really an exciting time, and part of it has to do with the advances that are being made in neuroscience at multiple levels: computational neuroscience, the development of new technologies, and the refinement of current technologies. And I think that we're kind of on the cusp of being able to focus on a number of problems, neurological problems that we may be able to provide some significant relief for. I almost said cure, but I don't want to get too far out of the realm of possibility. And I think that not only do I appreciate the organization providing the funding for our pilot project, because I personally think that it's really has a great deal of potential, but it's also very exciting for me as a researcher. But I also think that the one thing that we need to do more of, and just this session today is a good example. I think we need more collaboration. We have 3 people here doing things all focused on the same disorder from different perspectives, and I think that the more we can integrate that across the different perspectives, the better handle we're going to get on the disorder and be able to develop the kinds of approaches that we need. And in some cases, they may be individualized. In some cases, they may be something that applies across the population as a whole. So I appreciate the organization for doing this, and I hope you continue to try and keep us collaborating or facilitating our collaboration.
Vincent, I can tell you that as Dr. Honey can probably comment, certainly a major goal that we have and have worked and strived to do that. And in fact, that's where we're going to be spending even more time going forward. And in fact, Dr. Honey and I had some conversation here a few weeks ago about that. And, you know, a couple of the work you guys are doing. And then I know you didn't get a chance to actually speak directly with Scott Norris and Dr. Juergen. But again, all of this different work, you're absolutely right, that's going on, that there has to be some complementary things going there. And the collaboration is the only way we're going to be able to do that and accomplish it. So I appreciate all of you willing to collaborate and work with the other teams. And, you know, we're certainly in a position to help facilitate all of that. But ultimately, it comes down to researchers and research teams being interested in working with each other. So I appreciate your comments very, very much.
And Charlie,
Chris?
I would just like, I would just like to add, you know, what's exciting to us as an organization is, like with Dr. Gracco, he had reached out to the Dystonia Coalition, which we were part of, and that information was shared, and we reached out to him to talk and engage and see if there was an opportunity and for research. And so I think that's the exciting part, is especially with the aspect of being able to do things virtually, is that we are able to start having these conversations with researchers who may not be looking at SD right now, but maybe in a similar vein, and, you know, and kind of get them more engaged. And we've got a history of that with Dr. Teresa Kimberly, who was looking at writer's cramp and then got interested in SD. And so, you know, I think that's also the exciting part, is that our researchers are open to having conversations with us about potential. And even with Dr. Konczak, you know, we really wanted to have a study on AB with this treatment, and worked with them on recruitment and for patients and such. So, you know, I think that collaboration also is very exciting, and the respect between the organization and the research team. So we appreciate that aspect of it too.
Great. Thanks, Kim. Chris?
Oh, well, I would just congratulate the former National Spasmodic Dysphonia Association for drawing attention to this quite rare disorder. And there is only so many, you know, researchers in the United States, and they're busy studying other things. And I think you've done a great job to draw attention to this condition. And all of a sudden, in the last 5-6 years, oh, people are moving. Hey, let's study SD. Oh, that links up with my other work. And so drawing attention to the condition is very important. And then on the researcher side, we're at an early stage. It's like Parkinson's 18 years ago. And who knows which of these fabulous new treatments is going to be the one that, you know, oh, boom, everybody gets that. And so I think at the beginning, you have to have a variety of, you know, you're not just going down one road. It's early days. Let's have a series of them. And I think, you know, one of them's going to do really well. And then the last thing I think is the collaboration bit. So I would not have collaborated with the University of Indiana, you know, if Charlie and Kim hadn't said, you know, you got to link up with these people. And so I think it's a wonderful, you've set this network up. You've brought SD or dysphonia to the attention of researchers who might be able to do something about it. And, you know, thank you for your funding. And the funding comes from your stakeholders. So the audience, you know, your support has made a huge difference. Yeah, I think so. Congratulations.
Yeah, thank you, Chris. And a great point too of, you know, we couldn't do any of this without our community of just generous, incredible people providing the funding for us, because we're, as an organization, you know, we're not that large, because SD is a rare condition, so not that large of a patient base. but our community has just been so responsive over the years. And so to your point, Chris, fantastic. I can't thank our community enough for their support. And that's the only way that we're able to provide funding to you guys to continue this type of work. So it's clearly a team effort across the entire community, from the patients to the researchers, and the entire circle comes. It all comes full circle for sure.